Welcome to the next video where I'll be discussing how we manage treatment-related side effects in the palliative setting. In the most recent set of videos, we've been talking about the stage 4 unresectable setting, also referred to as palliative setting. And we talked about all the different therapies that we have available. We introduced the concept of lines of therapy, and how there are preferred regimens and treatment schedules in each of those lines, including chemotherapy and targeted therapies or immunotherapies as appropriate. We talked about the advantage or potential benefits of these treatments compared to no therapy at all or just best supportive care, referring back to historical data and showing that single agent chemotherapy or two chemotherapies together and through later lines of therapy can improve survival. And now with the introduction of targeted therapies and immunotherapies, when appropriate, can really increase that median overall survival time. We've also been talking about how it's a balancing act in terms of optimizing those treatment benefits, but limiting side effects. We've alluded to the fact that even in the best case scenario where the treatment's working in that stage 4 setting, in general, we expect that some cancer cells will be resistant to that therapy, and eventually that therapy will run its course and we have to change to later lines of therapy, and ultimately we run out of good therapeutic options. So we talked about chemotherapy examples, how they work, namely they inhibit cells that are dividing, and cancer cells divide, and that's why chemotherapies are so effective. But at the same time now, with this presentation where we're focusing on side effects, we get side effects from chemotherapies because normal cells also divide, and the chemotherapy can't differentiate between a cancer cell and a normal cell. And so we get what we refer to as collateral damage on normal cells that are dividing. So we have shown this slide in a number of our videos because I think it's important to understand that it really is a balancing act in terms of trying to optimize the advantages and the benefits from chemotherapy and targeted therapies, but limiting their side effects, and how in the setting of where the treatment's working, we try to limit side effects with dose modifications, delaying doses, maintenance approaches we talked about, and even chemotherapy holidays altogether. And in the setting of where the cancer is growing, where we initiate therapy, or if we're already on therapy, that say a maintenance regimen where we resume full chemotherapy regimens, or if you're already on a full chemotherapy regimen and it stops working, to change to the next line. And so this balancing act is really at the forefront in terms of what the oncologist is thinking with each visit with you, how we can optimize the outcome in terms of benefits, but limit the side effects. So the next set of slides, I just wanted to again revisit the 3-drug regimen versus 2-drug regimen topic, because it's a common question in the first line setting of metastatic disease, whether 3 drugs versus 2 drugs is the better choice. And in the context here of this presentation where I'm talking about side effects, and so also to introduce a new study that just came out that adds more information to this topic. So in the video on triplet therapy versus doublet therapy, we talked about this pivotal study, phase 3 study called the V325 study, which was looking at standard doublet chemotherapy, which at the time typically was cisplatin and 5-FU, versus a 3-drug chemotherapy regimen, cisplatin 5-FU, but the addition of docetaxel, a taxane drug, also called Taxotere. And you can see that it improved survival and progression-free survival in these figures, and also increased the response rate of about 10%. So 1 out of 10 patients more would have a response by using a 3-drug regimen versus a 2-drug regimen. We also talked about a second study that looked at modifying the drug doses of the DCF regimen so that you had a lower dose of docetaxel compared to the parent regimen, a lower dose of cisplatin compared to the parent regimen, and a shorter amount of treatment with 5-FU, 2 days versus 5 days. And somewhat counterintuitively, the modified lower doses of DCF did better in blue compared to the parent higher doses for both progression-free survival on the left and overall survival on the right. And the thought there is that it's because patients are actually able to tolerate this and get it longer and therefore work longer than the higher doses. And again, you can see here that the increase in response rate is around 10 to 15% in this study. So we also alluded to the fact that more recently, rather than using cisplatin-based therapies, oxaliplatin-based therapies have been more preferred because it's generally more tolerable. And the FLOT regimen, namely, which is 5-FU, leucovorin, oxaliplatin, and docetaxel. So it's otherwise very similar to DCF, but it's oxaliplatin instead of cisplatin. And you can see that the response rates and the progression-free survival and overall survival are similar to the DCF regimen in this single-arm, non-randomized cross-trial comparison. And then lastly, we talked about another triplet regimen called FOLFIRINOX, not as widely known, but there are studies that show that it can be effective in the stage 4 setting, and is showing here with good response rates, PFS and OS, again, in line with what one might expect with FLOT or DCF. And the advantage with FOLFIRINOX is that irinotecan does not cause neuropathy like docetaxel does, for example. So instead of docetaxel, irinotecan. Otherwise, it's the same regimen. And so we also talked about how generally a 2-drug doublet chemotherapy is preferred for first line for most patients, but it's an individualized discussion and personalized approach for patients. And if they feel like a 3-drug regimen, they want to take the risk of added side effects, but for this potential improvement in clinical outcomes, that's a decision that's made with your oncologist. In my preference, in my opinion, if I'm going to be using a 3-drug regimen, I prefer FOLFIRINOX because it limits the amount and the grade of neurotoxicity compared to, say, FLOT. Why are we talking about this in this video where we're talking about side effects? So just to take you through the V325 table here of side effects. First, for any chemotherapy, you can see on the left here common side effects that we expect: collateral damage on normal cells from the chemotherapy. And so it's grouped into major categories. Hematologic, so blood-based side effects, where the chemotherapy affects our bone marrow. And we talked about how the bone marrow is dividing rapidly to replenish our blood cells, our white blood cells, neutrophils, and other white blood cells like lymphocytes, our red blood cells that when they're low can cause anemia, and our platelets when they're low causes thrombocytopenia. And neutropenia is really the one that can affect our ability to fight off infections. And so particularly febrile neutropenia, where you have a fever and you have low neutrophils, this is a risk for significant side effects and potential serious infections. And then a second category is non-hematologic side effects. So not affecting the blood, but other organs. A very common one is the GI tract, because our GI tract from the mouth to the other end is always dividing and replenishing the most outer layer. And so from the mouth, stomatitis, sores in the mouth, to the gut, causing diarrhea, nausea, vomiting, and just lack of appetite, anorexia, are very common side effects with chemotherapy drugs. And then lastly, some more general symptoms like lethargy, feeling tired, fatigue, infections, as I mentioned, and specifically for some types of chemotherapies, namely platinums and taxanes, neurotoxicity affecting your nerves, your ability to have sensation in your hands, your fingers, and your legs and feet and toes. And so when you look over here now in the columns, you see the two main arms of the study, DCF versus CF. So the 2-drug regimen on the right, the 3-drug regimen on the left. And you can see, just focusing on the 2-drug regimen, there's sub-columns of any grade of side effect or really high grade. So we grade side effects in clinical trials from none to grade 4, 4 being more serious and significant. And so you can see the percentage of any grade side effects on the right column here, and those that are of higher grade, 3 or 4. And so 2-drug regimens have sort of a common rate of having these side effects. And now, when you look at in comparison to the side effect rates with a 3-drug regimen for any grade or for higher grades 3 and 4, you can see that across the board, 3-drug regimens have higher rates of each of these side effects, both any grade or, of course, most importantly, high grades for using a 3rd drug in comparison to 2-drug. So the real question, and I remember pointing out the editorial at the time, is the added benefit of using a 3rd drug warranted? Is it worth it? Or does, as Dr. Ilsen mentioned here, does the punishment fit the crime here? So again, the general sense from most oncologists was that added benefit really is not justified in most patients for the added side effects that we have to experience in most cases. And again, it's an individualized decision after discussing the potential risks and benefits and making that decision for you and what's right for you. But in general, using a 2-drug regimen and then using 2 or 1 drug tandem in 2nd line, 3rd line, and higher, et cetera, it, for the most part, can get us to the same point, but with lower side effects. That's been the general sentiment. So what I wanted to also add here, because since we did the 3 versus 2 drug video, a newer study, a phase 3 study came out at the recent ESMO, European Society of Medical Oncology annual meeting last month in October. And so what this study was is essentially a modern V325 study. It's basically the same study, except instead of cisplatin 5-FU as the control arm, it's 5-FU and oxaliplatin. So oxaliplatin instead of cisplatin. And in the 3-drug regimen, it's FLOT instead of DCF. So it's basically looking at the same study using oxaliplatin instead of cisplatin. And what we see is essentially the same result as what we saw with the V325 study, and that is that the FLOT regimen had a longer median overall survival and a longer progression-free survival with a hazard ratio of 0.82. And remember, that's a good number to be using to compare other studies looking at similar designs. And so, for example, the hazard ratio of survival in the V325 study was very similar to this. So in my view, there's not much new learned from this study other than FLOT is a little bit better than FOLFOX in terms of clinical outcomes, to the same degree that DCF was better than cisplatin and 5-FU. And the same discussion then afterwards takes place, and that is it worth the added side effect profile? And so similar to DCF versus CF, there's about 1 in 10 patients that'll have a response with FLOT that wouldn't have had it with FOLFOX, as you see here on the bottom. And really the point here to bring out in this video about when we're talking about side effects is the side effect profile, of course, is higher with a 3-drug chemo regimen versus 2-drug. And specifically where you see that neuropathy, grade 3 neuropathy is higher, and even grade 1 and 2, which is higher, is not insignificant. Grade 2 neuropathy can still affect negatively your quality of life. And so this has to be kept in mind. In addition to that, you see higher rates of diarrhea and higher rates of grade 3 or higher neutropenia. So again, it's this philosophical question, is this added benefit worth it for the added side effect profile? And again, it's a decision that's made after a full discussion of potential benefits and risks and what is best for you and your own goals of care. So the next topic I wanted to bring up is the differentiating side effects from the actual therapy versus symptoms from the actual cancer. And in one of the first videos we did when we were talking about diagnosing the cancer and symptoms from the cancer, we talked about symptoms that the primary tumor can cause, the primary tumor being where the cancer started, originated in the esophagus or stomach, versus metastatic sites where the disease has spread to. And each of these can cause symptoms from the actual cancer. And here in detail, a list of those that symptoms that can be from the esophagus or the G-junction or the stomach, which there's some overlap, but there are some unique symptoms for each of these primary tumor sites. But what I wanted to point out is that there are a number of cancer-related symptoms that overlap with treatment-related side effects like nausea, vomiting, feeling tired, in this case from iron deficient anemia from bleeding from the primary tumor versus feeling tired from anemia from the chemotherapy side effect. In addition to nausea and vomiting, we have loss of appetite and vomiting. And so how do we differentiate between the cancer-related symptoms and side effects that can lead to the same feeling that you're experiencing? And similarly with metastatic disease, which again means where it's spread to, and that it can be spread directly to regional places. A common direct extension is from the stomach into the peritoneal cavity or through the lymphatic channels to lymph nodes, both near and far lymph nodes, and through the blood to other organs, most commonly the liver, the lung, and the bone, but also less common sites like we talked about with the brain. And so again, there are side effects from chemotherapy that overlap with some of the symptoms that these metastatic sites can cause. Neuropathy from the chemotherapy is usually symmetric and usually in the hands, fingertips, feet, toes, and can come up the bottoms of your legs if it gets severe. Whereas neurologic symptoms from metastatic disease, say like in the brain or in the spinal cord, are usually more focal, like one-sided, or more like cognitive issues. And so usually can be differentiated from side effects from, say, neuropathy from the chemotherapy. But there are more general symptoms from metastatic disease, like fatigue, weakness, like fevers that are attributed to the tumor itself, like loss of appetite, weight loss, like nausea, vomiting, and an exacerbation of other medical conditions. Each of these can be caused from metastatic disease or from side effects from the actual treatment. The last one, exacerbation of other medical conditions, is because any stress on our body, whether it's from cancer or from chemotherapy, can exacerbate underlying medical conditions that are chronic to you, whether it's congestive heart failure or diabetes or COPD, emphysema, or any other chronic medical condition can be exacerbated. So how do we differentiate then the symptoms from the cancer versus side effects from the chemotherapy? Well, there are a couple of things that the oncologist is doing as they're listening to you and you're reporting how you're feeling. And so generally, treatment-related side effects are temporally related to the dosing of the cycles you're getting. So for gastroesophageal cancer, generally our chemotherapies are given every couple of weeks, every 2 weeks on 2-week cycles, sometimes every 3 weeks, like say DCF. And so we usually see the first day or two, actually, you don't really have dramatic symptoms. In fact, some patients feel better because they're getting pre-medicated with steroids in some cases. And so that can actually make you feel a little bit better for a day or two. But then it kicks in, and I usually tell my patients that it sort of peaks, it's at its worst 3 to 5 days into the cycle, and then over time it gradually dissipates and improves until the next cycle in general. And so the key is to minimize those peaks in terms of how bad each of the symptoms gets as much as we can. And so we start with standard doses of each of the drugs in your regimen. And if necessary over time, as we hear how you did with each cycle, we can tweak that and modify one or more of the drug doses if necessary. And ultimately, the goal is to find that sweet spot of treatment dosing that is adequate to control your cancer, but is limiting your side effects as much as possible. And that balancing act or sweet spot of dosing is often obtained through fine tuning over a few cycles, because again, we're starting with just general height and weight to dose you based on standard dose levels, and then we can tweak that to personalize it over time, and that works best for you based on how you're doing with each cycle. In contrast, cancer-related symptoms generally don't fluctuate like the treatment-related side effects, whereas with the treatment-related side effects, we're seeing this uptake initially, and then it sort of dissipates over time. Cancer-related symptoms usually don't do that, and they can be intermittent, but there's no rhyme or reason to it, and you can't pinpoint, well, it was around this time of my cycle every time. Cancer progression is not obvious sometimes on scans. We've talked about that, particularly with peritoneal disease. Sometimes we use tumor markers and even circulating tumor DNA to help us in those situations, because they could be rising even though, say, scans show stability. And so in some cases, though, especially with peritoneal disease, diffuse type gastric cancer, the scans don't show growth, tumor markers don't really show anything, and the ctDNA doesn't show anything. Yet we are having worsening symptoms, and we feel like this is possibly due to cancer progression in the, say, the peritoneal cavity, and not likely related to treatment. Ultimately, in those situations where we're still not 100% sure if it's from cancer-related symptoms and worsening of the cancer versus treatment-related side effects, time always tells, especially when we give a break to the treatment in the event that we think it could be related to the treatment. And the cancer-related symptoms in those situations would definitely worsen over time on those delays and holidays, because they're not just going to get better on their own. Whereas if it's from a side effect from the treatment and we're giving you a break from the chemo, then usually those symptoms slowly recover and improve. And so again, time always tells whether it is treatment-related side effects or cancer-related symptoms. In many cases, it could be both. You're having worsening cancer and side effects from the treatment, and you're not feeling well due to both of those reasons. And so in that situation, it makes a lot of sense to switch the therapy, because it's not working and it's causing side effects. So this is a figure just to show you pictorially what I was talking about. And so what you see here is over time, say with FOLFOX or any regimen, this is a regimen that's given every 2 weeks, where on the first day you get your first day of treatment, your first cycle. A week later, and then 2 weeks later, you get your second cycle. A week later, and then a week after that, you get your third cycle. So every 2 weeks, you're getting treatment. And so no matter what side effect we're talking about, whether it's nausea, vomiting, or fatigue, or diarrhea, or whatever, we typically see, again, the first few days are sort of okay, and then we see it start kicking in and peaking after 3 to 5 days, and then slowly dissipating over time, so that by the time you're due for your next cycle, you've recovered and you're able to proceed and get your next dose. Everyone's different though, and the next person may experience each dose a little bit worse for one or more side effects. And so ultimately, after each cycle, reporting how you did is really important, because we can modify the doses to try to minimize or limit those side effects that you're experiencing, to make this as low as possible with each cycle. Next, we'll talk about some unique side effects, which we've been alluding to along the way through a lot of the videos. And the first one is neuropathy, sensory neuropathy, where we're talking about platinums and taxanes, typically in the regimens that we're using for gastroesophageal cancer. When we talk about platinum neurotoxicity, I've mentioned that oxaliplatin generally has worse neuropathy rates than cisplatin. But overall is otherwise more tolerable in terms of causing nausea, vomiting, and fatigue, etc. And so over the years, oxaliplatin has been more preferred over cisplatin for that reason, but it comes with this neurotoxicity. There are two types of neurotoxicity. The first is cold sensitivity. You're sensitive to touching cold things, whether it's your hands, your feet, or drinking cold things in your mouth and as it goes down. And usually this onset can be immediate with your first cycle. It can be like on the way home from getting the treatment. And again, it actually mirrors those figures I showed on the previous slide, where it usually kicks in, there's a peak over a few days, and then it sort of dissipates over time, so that by the time you get your next dose, it's pretty much gone. On the other hand, there's a second type of neuropathy, which is cumulative. You usually wouldn't feel this initially, but over many doses, typically by 8th dose, for sure by the 12th dose, sometimes even earlier in some people, you start to feel this numbness, tingling. Some experience it as pain. that is lingering longer and longer after each cycle. And in the worst case scenario, if you kept treating with more and more of this oxaliplatin, it would linger and be present even after stopping the treatment months and even years later. And that's sort of like a permanent damage that's taken place in the nerves. And the reason why we really worry about this, other than the discomfort, the numbness, the tingling, and sometimes pain that patients can experience, is what's listed here is that if you really push it, the real problem becomes balance issues and dexterity. So you can't feel your feet well, so you lose your balance and you can be falling, which can be dangerous. And similarly in your hands, you lose your dexterity, you can't hold things, you're dropping things. And so we wouldn't want to let it get to that point. And so that's why we pay attention closely to oxaliplatin-related neuropathy. And the last thing to say about this neuropathy is that it's usually a lagged onset. And so you're getting your 8th dose, but how you feel that day before you get your 8th dose is really reflecting what you've received a few months earlier. So only up to, say, your 4th or 5th dose is what you feel now. And you haven't really felt, or the treatments, the 6th and 7th dose haven't really kicked in yet. And so trying to anticipate how you will feel 2 months later is always part of what the oncologist is doing, and trying to convince you maybe it's time to stop this. Even though you don't feel so bad right now, I know that it's going to come. And since the cancer is well controlled right now, we can afford to maybe put the oxaliplatin on hold for a little while so that we limit that neuropathy. That's, remember, referred to as maintenance therapy, and using Optimox, so optimizing the use of oxaliplatin. Similarly, taxanes can also cause this neuropathy. It doesn't usually cause the cold sensitivity issue, but it can cause that longer standing neuropathy, and the consequences thereof, like balance and dexterity over time. And so again, using these two drugs together can compound that and accentuate that, exacerbating these side effects, or even in tandem, using one, then the other can sort of add to the prior residual oxaliplatin-related neuropathy. Next is diarrhea. Any chemotherapy can cause diarrhea, but a notorious agent, irinotecan, can cause diarrhea. And we talked about the enzyme that metabolizes this drug. And some of us in the population, about 10%, are at high risk of having an inability to metabolize this well, so it lingers in our body longer. And so some oncologists use this information to preemptively dose reduce this in those individuals who have high risk copies of the gene of that enzyme. Certainly, if you're having significant diarrhea, or whether or not you had a preemptive dose reduction, it would warrant future dose reductions of irinotecan, or maybe stopping it if it was really severe. The next sort of unique side effect that pinpoints to a specific chemotherapy drug is what we refer to as hand-foot syndrome. And so this is more typically from the oral version of fluoropyrimidine, the capecitabine or Xeloda, less so with the IV 5-FU, especially with a 2-drug regimen. More common back in the days when we gave it over 5 days, say with the original CF, cisplatin 5-FU regimen of a 5-day infusion, can be more common to get hand-foot syndrome. Regardless, what is hand-foot syndrome? It's changes in the nails and the skin in the hands and feet, peeling and tenderness in the palms and soles of the feet, and to the point where, like, if you keep taking the treatment, it can get to the point where it's really sensitive and causing problem. It's not life-threatening. When you stop the drug, usually over a few days, it recovers and would merit a dose reduction, or if it's really significant, considering stopping it altogether. In this slide, I just wanted to point out again a concern that many patients have, and that, what if I need a dose? My doctor wants a dose reduction, and should I do that? Will it compromise the control of my cancer? And so remember, in that palliative setting, our goals of care are to control that cancer as best as possible, but also limit the side effects. It's a marathon, not a sprint. And so if we're overdoing it with side effects, we're not going to get through it. We're not going to be able to do this for a long period of time. And so generally speaking, that's why when we're talking about in that conversation of 3 versus 2 drugs, in general, because it's a marathon and not a sprint, we're talking about using one or two drugs in tandem over time through the lines of therapy to make it better tolerated, to improve and optimize our quality of life, and still have disease control. And this study on the left, again, emphasized that patients who were considered elderly and or frail and enrolled into this study, who were randomized to getting a full dose of standard FOLFOX chemotherapy or a dose modification preemptively because they were elderly or frail, did not compromise overall outcomes, and that some therapy, in other words, is better than none. And so ultimately, we want to give you what we think is the best dose for you to optimize outcomes and minimize and limit side effects. And lastly, the groups of patients who were really felt it was questionable to get any therapy because they were relatively frail, more frail, and they were randomizing to getting best supportive care or a really modified dose of 60% of the treatment. Those patients that got the modified dose did better than nothing at all. And so again, when we're talking about side effects, we can liberally dose modify our treatments to make it tolerable so that we optimize your quality of life. And essentially, this still gets us a better clinical outcome than not doing anything at all or plowing through with full doses despite the side effects. So we talked mostly so far about the chemotherapy, the FOLFOX backbone, the FOLFIRI backbone, the paclitaxel, docetaxel. But now, what about the targeted therapies? How do we deal with side effects from the targeted therapies and the immunotherapy? So first, let's look at HER2-positive disease for trastuzumab. We know that trastuzumab significantly improves outcomes when added to chemotherapy versus chemotherapy alone in the first-line setting. In terms of side effects, again, looking at the chemotherapy plus trastuzumab versus chemotherapy alone, and all the different potential side effects that are present, whether it's any grade or higher grade for the two arms. If you look through these columns, you can see that there's really no difference. And in other words, there's really no significant increase in side effect profile from using trastuzumab, Herceptin, in patients that are HER2 positive. So it's got huge benefit and very little to minimal or none in terms of side effects. The one side effect that we're accustomed to looking for is heart dysfunction or cardiomyopathy. It's really not that common, and you can see less than 1% of patients in either group experienced any issues with the heart, but because it was noted that it could affect the heart in early studies, we still routinely look with ultrasounds of the heart to just monitor the pumping function over time every 3 or 4 months, just to be sure that it's not being negatively affected. But overall, like I said, it's very uncommon actually to have issues with trastuzumab. What about immunotherapy drugs, anti-PD-1, PD-L1 therapies, now relevant for PD-L1 positive tumors and HER2 positive tumors, typically those that are HER2 positive, PD-L1 positive that we've talked about. So again, we know that this therapy works well in those patients that have higher levels of PD-L1. Why and how does that work? Remember, the cancer cells are using PD-L1 to turn off our immune system, our T cells that otherwise would recognize them and kill them. And so immunotherapy drugs called immune checkpoint inhibitors bind to either PD-1 or PD-L1 and block this interaction so that then the T cell can get turned back on and attack the cancer cell. We've talked about a number now of these anti-PD-1 or anti-PD-L1 antibodies that are available. In my mind, they're interchangeable. At the moment, pembrolizumab and nivolumab are the two that are approved for this type of cancer. And so in the future, maybe that more of these are, but essentially the conversation is the same for any one of them. Again, when we look at under the microscope, the cancer cells, they can have complete negativity for PD-L1 expression, or they can be very strong. And we've pointed out that the tumors that derive benefits from these checkpoint inhibitors are those that are expressing at least a little bit of this PD-L1 protein. And so why do we really emphasize that we want to give these drugs to only those patients who could derive benefit or have a chance to derive benefit is because these do also cause side effects, because our normal cells express PD-L1 as a way to prevent autoimmunity, to tell our immune system, this is me, don't attack me. And so if we inhibit that, we can unleash our own immune system on our own normal cells. And there's a whole list of potential side effects that immunotherapy drugs have been reported to cause from various organ systems in neurologic, respiratory, kidneys, blood, skin, eyes, cardiovascular, our endocrine glands, our GI tract, and or rheumatologic bones and muscles. And any or all of these could occur. And so again, we want to give these therapies only to those patients who have a chance to benefit from them, because we could cause all of these potential side effects. And the common ones are listed here. So what if you're on an immunotherapy drug and you're experiencing some of these side effects to the point where the oncologist feels that the benefit or potential benefit from the drug is now being outweighed by the side effects? Well, we would stop the immunotherapy drug and we would treat first with a course of steroids, which suppresses the immune system. And in some cases, that's not enough, and we need to add other immunosuppressive agents if it's serious and severe and it's not improving with the steroids. So that's how we would treat the immunotherapy side effects. Now, looking at what's the rate of this in our patients, looking at one of the many phase 3 studies of immunotherapy drugs, say in the first line setting, this is from Checkmate 649, but it's very similar across any of the studies that we look at. And that is that the chemotherapy plus, in this case, nivolumab or Opdivo versus those of just the chemotherapy arm are higher. And so in grade 3 or higher, toxicities of any treatment-related adverse event was 15% higher. And many patients are having serious treatment-related adverse events, and patients are requiring to stop their therapy because of these adverse events. And you can see there's a slightly higher risk of treatment-related deaths, usually from pneumonitis affecting the lungs, autoimmunity in the lungs. Again, when we look at the most common sort of organ categories that can be affected by the immunotherapy and comparing the two arms, you can see that they're higher in any grade for sure, and even in grade 3 and 4 to some degree for each of these organ groups. So what's next? Zolbetuximab, which to date, even at the time of the end of November 2023, it's not yet approved by the FDA, but it's anticipated to be, and for patients that have a high claudin expressing tumor. So we know that there's benefit by adding this to chemotherapy, but it comes with an added risk of side effects. You can see the zolbetuximab arm compared to the placebo arm for any grade was pretty similar, because there was almost every patient had some form of side effect, whereas grade 3 or higher was about 10% higher in the zolbetuximab arm compared to placebo. And more patients ended up having to stop the therapy because of side effects compared to the placebo. You can see more than 10% of patients. Treatment-related side effects that were thought to be attributed to their death was not much different between the two arms, however. The one thing to note here is that when you compare the agent zolbetuximab versus the control arm, and you're comparing all the potential side effects that are there, you can see that any grade, which is the lighter color pink versus the lighter color gray, is typically higher across the board with the zolbetuximab arm, specifically nausea, vomiting, and decreased appetite. And similarly for the higher grades, 3 or higher, the dark red versus the dark gray is again higher, particularly for nausea, vomiting, also lower blood counts to some degree, but otherwise a lot of things not much different. So with respect to the nausea and vomiting, the one thing that's really important to know is that it typically is front loaded. It's in the first couple of cycles, and then afterwards, as time goes on, for both nausea and for vomiting, it's pretty similar between the zolbetuximab versus a placebo. So the highest grades are shown in the dotted line, and any grade, nausea and vomiting, are shown in the dark line. So with the red, zolbetuximab being higher compared to the placebo in both groups. So again, it is a known side effect, but it is front-loaded, and there are some strategies that have been incorporated, like infusing it slowly at the time of infusion, giving a liter of normal saline fluid can be helpful. Anti-nausea, pre-medications, etc., can all help. What's next? We have ramucirumab in second line. We know ramucirumab is an anti-angiogenesis drug that prevents blood formation to the tumor. There are a number of different types of drugs in this class of anti-angiogenesis. The one drug that's approved currently is ramucirumab, an antibody that binds to VEGF receptor 2. And there are some classic side effects that are attributed to anti-angiogenesis drugs. So showing the studies of ramucirumab on the left was the REGARD study, the monotherapy ramucirumab versus placebo. And on the right is the RAINBOW study, ramucirumab plus paclitaxel versus placebo plus paclitaxel. And what we saw in those studies was overall not much increase in side effect except for some certain things. High blood pressure, hypertension was significantly higher in the ramucirumab arm. Blood clots in the arteries, slightly higher, as you can see. In the chemotherapy combination, higher fatigue, higher bloody nose, higher vomiting, higher peripheral edema or swelling in the peripheries, high blood pressure, sores in the mouth, stomatitis, and protein in the urine. When we look in the urine and we can see protein loss, very common side effect from anti-angiogenesis drugs. And then lastly, low albumin in the blood, thought because you're eliminating it in the urine. It can also accentuate the side effects on the blood counts across the board. So ramucirumab overall is considered very well tolerated, especially as a monotherapy, but even in combination. But it can accentuate some of these side effects that chemotherapy causes, like low blood counts. And it has some unique specific side effects like proteinuria, low blood protein levels, and bleeding and high blood pressure. So if you're experiencing particularly really significantly high blood pressure that can't be managed with medication, then that would be grounds to certainly stopping, at least temporarily, the ramucirumab, if not indefinitely, if it can't be brought under better control. Lastly, we have trastuzumab deruxtecan, which we've talked about be using either in the second line or third line setting. And this, remember, is a targeted therapy, but also a chemotherapy. It is a targeted therapy, trastuzumab, binding to HER2, but it's connected to or conjugated to a chemotherapy drug called deruxtecan in the same drug class as irinotecan. And so we see side effect profiles very similar to chemotherapy, and that's shown here. So in the first study, Destiny Gastric 1, where TDXD or trastuzumab deruxtecan in HER2 was being compared to single agent chemotherapy, either paclitaxel or irinotecan. And you can see that side effects across the board were typically higher, both any grade as well as high grade, grade 3 and 4 toxicities with TDXD versus the single agent chemotherapy. And again, that's because it is chemotherapy. And I always want to point out a unique side effect of the TDXD, and that is pneumonitis, inflammation in the lungs. And in the initial report, from the abstract report, we saw that about 10% of patients had some form of pneumonitis, and about 2.5% of patients high grade. We also saw in the follow-up study, Destiny Gastric 2, relatively high rates of side effects, very similar to what one would experience with chemotherapy. And again, there was the pneumonitis or interstitial lung disease, ILD, that was, again, really specific to TDXD as a side effect. We talked about that because of this, in the second line setting where paclitaxel and ramucirumab or FOLFIRI and ramucirumab are standard options that don't cause same pneumonitis versus TDXD, although there is some evidence that using in second line from the Destiny Gastric 2 study can be useful, this balancing act of minimizing side effects, in my view, I would wait for the results of the ongoing phase 3 head-to-head study called Destiny Gastric 4 before using T-DXd in that second line. Other oncologists feel differently, but my opinion is, in the meantime, we have good options in that second line setting, whether it's chemo plus ramucirumab or chemo plus continued trastuzumab beyond progression, which there's ample evidence to do so, and save T-DXd till later when we don't have great options, and the risk of pneumonitis is then more acceptable. Specifically because with the final report of this pneumonitis risk, where we look at all the different effects on the lungs, that the risk of ILD pneumonitis was a little bit higher with longer follow-up, which suggests that the longer you're on therapy, the more risk you have of developing pneumonitis. And so any grade was around 15, even up to 20%, depending on how you classify the pneumonitis. And higher grade, 3 or higher, was almost 5% of patients. So it's relatively significant, important to know about. And if one is to develop pneumonitis on scans, which would be lower grade but not symptomatic, or symptomatic higher grades, the recommendation is to stop the treatment and to treat with steroids and follow very closely. And in most cases, especially if it's higher grade, not to re-challenge with that agent. So we look now here at this bird's eye view of all the various therapies that we have at our fingertips for treatment through the various lines of therapy. And we've talked about in the individual videos for each of these subgroups the potential benefits. And now here we're talked about each of the potential side effects of chemotherapy, targeted therapies, and immunotherapies that are used in this disease. So how do we manage these side effects? The treatments for these common side effects like nausea, vomiting, diarrhea, and low blood counts, we have some preemptive treatments that we give before and or on the day of your cycles, and even into the first few days of the cycles. So for nausea and vomiting, we give anti-nausea medication as pre-medication and over the next couple of days. And then you have some available to you at home through the rest of the cycle to use on an as-needed basis liberally to really catch it early so it prevents it from getting severe. Same thing with diarrhea. We have preventative medications that we can prescribe and certainly use if you're having symptoms. And similarly for low blood counts, especially if you've actually experienced that on your treatments, where we can give a preventative growth factor booster, often called Neulasta or pegfilgrastim, to prevent the white blood cell count from bottoming out. And in some regimens, like a 3-drug regimen like FLOT, we preemptively do that even from the get-go, from the first cycle. Yet there are some side effects that we don't have any preemptive treatments for, like fatigue, weakness, feeling tired, and neuropathy from the neurotoxic drugs. And similarly, if you're experiencing these symptoms, say of nausea, vomiting, despite our optimal medical management, or diarrhea, what else can we do? Well, we've alluded to all of the different things that we can do, including dose delay. So you're not ready for your next cycle, your counts haven't recovered enough, you're still feeling a little queasy, we can delay it a week. It's not the end of the world. It's very common to have to do that so that your counts recover to the point where we can redose. Dose modifications, dose reducing one or more of the agents in the regimen to prevent that from happening again, or to minimize the degree at which it's happening. Dropping out components of the regimen. I've always talked about the 5-FU and leucovorin bolus, which in my practice, I often don't even use at all. But certainly if you've started with a bolus of the 5-FU, that's one of the first things I stop if they're running into any trouble with any of these side effects, because that's usually the main culprit. The continuous infusion that you go home with over the next 2 days is usually not causing these side effects to any significant degree. Usually, if you're not on the 5-FU bolus and you're experiencing these side effects of nausea, vomiting, diarrhea, fatigue, despite not having the bolus, it's usually because of the second drug added to the 5-FU, or in the case of a triplet regimen, the 2 drugs. And so dropping that second drug out, dropping out oxaliplatin, dropping out irinotecan, dropping out one of the two big guns I refer them to, dropping out the docetaxel or dropping out the oxaliplatin, can really make the regimen more tolerable and maintain that quality of life, yet not compromise our ability to control the cancer. So all of these things are on the table in terms of management strategies that we can use if you're having side effects along the way. And that's why it's really important to report what you're feeling to the nurse that's giving you the next dose of chemo, or the physician if you're meeting with them, so that they can incorporate that into their treatment decisions in terms of what to do. And again, a cautionary note, sometimes patients don't really want to say how they're feeling because, again, they feel like they don't want the drugs to be stopped or dose reduced because they don't want to have negative consequences on their control of their cancer. But I've been trying to show you evidence that suggests the contrary, that making it tolerable actually is more important because it can keep you on the therapy longer and actually make it work better over the long run. Again, it's a marathon, not a sprint in this situation. So with our final slide here, just emphasizing how it really is a balancing act, that we're trying to optimize the control of the cancer, but limiting side effects. And again, addressing the question of, so does this mean I need to be on treatment indefinitely or forever? The answer is, in a way, yes, in that stage 4 disease setting, but with the built-in maintenance and holidays as possible and as we can if your cancer is well controlled. And I usually liken it to other chronic medical conditions, like, say, diabetes, that needs, say, insulin, and you need to take your insulin every day. But if you do so, then we can control that disease for long periods of time. And the same is true in this setting of stage 4 gastroesophageal cancer, where as long as you're getting your treatments on a regular schedule, and it's tolerable and you have a good quality of life, that's the optimal and ideal outcome, is that we're able to control the cancer as long as you're getting your therapies, again, by building in maintenance and holidays as we can. The difference a little bit between, say, the diabetes analogy and cancer is that the diabetes often can be controlled on the order of decades, whereas with cancer, because of the development of resistance, it is not an identical analogy where we start to see resistance develop and we have to switch our therapy to something else. And ultimately, we run out of good things to switch to after each line of therapy has stopped working. But it's the same concept in that as long as we're getting our therapy and we found that sweet spot that seems to be working, tolerable, our quality of life is good, and life goes on as long as you're getting your treatments. So in this video, I reviewed the treatment-related side effects that are possible from the various treatments that we give in this palliative setting, including chemotherapy, targeted therapies, and immune checkpoint inhibitors, namely anti-PD-1 and anti-PD-L1 therapies. And I also alluded to the very common topic of 3-drug versus 2-drug, and provided some updated study information of looking at FLOT versus FOLFOX. And again, the discussion as to what option is optimal for you after discussing the potential risks and benefits of the treatment. We talked about how it's the oncologist's job to try and differentiate between treatment-related side effects and cancer-related symptoms, and sometimes the difficulties that ensue with that discussion. And we also talked about strategies to limit the side effects, both preemptively in certain situations and also over time with an iterative approach after each cycle, trying to fine-tune, tweak the regimen doses and the regimens to make them work for you, to again achieve that optimal balance or that sweet spot, limiting side effects but optimizing control of the cancer. So thank you for your attention in this very important video.